This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Good morning. We're going to get started with grand rounds as people trickle in. Today's speaker is Dr. Miriam Parsa, who's a faculty in the Division of Pediatric Allergy, Immunology, and Rheumatology over here at David Geffen School of Medicine and Mattel Children's Hospital. Miriam received her MD from Albany Medical College, a master's degree in public health from Yale University School of Public Health. And then she completed her pediatric residency training here, followed by a fellowship in pediatric rheumatology here at UCLA. She has received grants that have allowed her to set up the first pediatric rheumatology center to utilize ultrasound in research and clinical practice here on the West Coast. And she's currently working on establishing standards of treatment for children with uveitis through the Childhood Arthritis Rheumatology Research Alliance and the UCLA Uveitis Group. She was awarded the American College of Rheumatology Distinguished Fellow Award and continues to be an active member of the North American Pediatric Rheumatology Ultrasound Group and is a board member of the Arthritis Foundation. So the title of her talk today is When It's Not Just Growing Pains. Miriam Parsa.
Good morning. Thank you, Dr. Devaskar. Thank you for the invitation. It's an honor to speak in front of all of you. So today I'm going to talk about joint pain in children. Some objectives. I'd like by the end of the talk for you to understand the differences between inflammatory causes of joint pain versus non-inflammatory causes. I want you to think about the differential diagnosis when you have kids coming in with joint pain. Have an understanding about basic labs and imaging testing that might be useful. Describe some basic treatment options, at least have an understanding about what we used quite typically to treat chronic arthritis. And talk about a little bit of the cultural diversities that we do see in these diagnoses. I have no disclosures. This is what we're going to talk about today. So I'm going to first talk about arthralgias. That's by definition joint pain. Then move on with the case presentation to discuss arthritis, which is joint pain caused by inflammation. And I'll discuss the differential diagnosis based on the number of joints involved. So differential based on oligo presentation, which are 4 or less, poly presentation, and then arthritis with systemic features. Talk about imaging and basics of treatment. So we'll first start with the case. I have some maybe new interns, welcome, and new second and third years, congrats. We have a 2.5-year-old male who comes into your office with complaints of leg pain during late afternoon naps. Parents note that the complaints really are increased after a particularly busy day playing with brother and sister. The duration is not a week. It's really been going on for about 3 or 4 months. So because of that duration, parents are beginning to be a little bit worried. Alleviating factors are heat pad, and there is a family history in the father of something similar when he was a young child. So you do a nice, thorough physical exam, and you learn your MSK exam after doing a rotation with us in pediatric rheumatology. So you're confident about your MSK exam, and everything's normal. So this is him. He's healthy, active, playful. He's very, very cute. This is my gratuitous picture of my son. So what should you think about when you have a kid coming in with joint complaints? In pediatric rheumatology, we are always thinking about this Venn diagram of infection, hematology, oncology, and autoimmune diseases, as well as orthopedic issues as well. So obvious infection-related issues being primary etiology, inflammatory malignancy. We'll talk about this in a little bit more detail, as well as orthopedic causes of joint pain, specifically hip pain, trauma, and non-inflammatory causes, which I'll get to. So let's talk about arthralgias. Growing pains. It's not this growing pains. I don't know if I'm totally dating myself. But this is where Leo DiCaprio made his debut. It was my favorite show as a young person. So not that growing pains, but a benign cause of pain in childhood. Really, it's not related to growth. So they've done some studies looking at when these complaints are occurring, and it's really not within that accelerated period of growth. So it's a bit of a misnomer. What's thought to be the etiology is local overuse. And again, that fits with the history of a particularly active day and then having more pain complaints a little bit later. It affects kids of all races, particularly in the younger kids, 2 to 11 years of age. And again, you're going to get that family history, so ask about family history of growing pains. So what's thought is that these kids are a little bit more pain sensitive. And what you'll also find on history is chronic headaches, chronic abdominal pain as well. Alleviating factors are the heat, massage. Some parents will give some ibuprofen or acetaminophen, and that does make a difference. So when should you be comforted by the fact that this is growing pains? Because again, this is a benign process versus something that needs additional workup. So there is criteria for growing pains. And typically the pain occurs late in the day, or it can awaken the child, so that can be disruptive to everyone's sleep patterns. It's severe enough to interrupt some normal activity. The pain is not specifically in the joints. Patients will describe, or kids will describe, lower extremity pain. So they're pointing to non-specifically their whole entire lower extremity. It occurs at least monthly for at least 3 months, and this really shouldn't be a persistent, consistent complaint, as you'll hear me talk about with a chronic arthritis, which is, by definition, persistent and more consistent. There should be some symptom-free periods. And again, like we discussed, the pain is worse after a really busy day. Key point, physical exam, totally normal. Key point, lab studies are totally normal. So if your kid doesn't fit nicely into this, then you need to consider some of the other things I'm going to talk about in a little bit. So other causes of joint pain. Hypermobility. This is evidenced by the Peter Paul Rubens painting, Three Graces. As you can see here, they have some cardinal features of hypermobility. You have some hyperlordosis here, a little scoliosis, maybe a little bit of hindfoot or pes planus. I might be reaching a little bit. And then hyperextension of the MCPs. So these it was described that these were siblings, and they probably all had some degree of hypermobility. So there is an entity called Benign Hypermobility Syndrome. And as you know, being in pediatrics, that there is it's normal to have some hypermobility during development. So these kids are beyond what would be considered normal hypermobility of the childhood. And it's actually quite common. I saw a stat about 80% of elite ballet dancers have benign hypermobility syndrome, and you could believe that too, right? That's part of their job. So about 20% of the white population meet this criteria, but really what we see in clinic, a lot more have this, but they don't necessarily meet the criteria, which I'm going to talk about on the next slide. So on history, you're going to maybe hear of a slightly delayed time to walk. About 15 months was the median in one study. And they might be a little clumsy, a little poor coordination, but this is, of course, with a normal neurologic exam. They might describe a history of brief joint swelling. That's opposed to joint swelling that lasts days and days and days, weeks, which you're going to be thinking about other things. So physical exam, I'll describe the Baton score in a moment, and that's what we used to classify kids. You'll also find in physical exam flat feet, hind foot valgus, as well as genu recurvatum. And quite commonly, fibromyalgia is a secondary diagnosis to the hypermobility syndrome. So this is the scoring system that we use. And in order to meet criteria, you should have 4 out of 9 points. And I'll just let you look. So I don't know if anyone's trying to test themselves at this point, but that's what I did the first time I came across this scoring system. So another cause of joint pain is patellofemoral syndrome, and we see it quite commonly in adolescent females. And that's what thought to be an imbalance of the quadricep muscles. In particular, it's probably some patellar instability, and so what kids are describing when they describe their pain is that patella coming outside of the trochlear notch, which it should be in a nice, comfortable position. So, and that's because theoretically there's that imbalance of the 4 quadricep muscles pulling one direction versus in a balanced direction, or no particular direction. So you're going to hear a history of crepitus, pain with stairs and squatting. And then on an exam, you're going to have the patient lie supine and press on their patella bilateral, and you can elicit some pain because you're essentially having the patella come out of that trochlear groove. Treatment is physical therapy. You'll hear me say physical therapy a lot. So we rely on our colleagues in physical therapy to help us with the management of our kids with joint pain. And they're going to be working on hip abductors primarily, but also that vastus medialis muscle, which can be underdeveloped in this adolescent female group. So going back to our case presentation, so diagnosis growing pains, there was nothing alarming in the history and physical exam. And workup really didn't have to do any labs. You felt confident based on what you learned today that you didn't have to do any lab work or imaging. And really it's about education. This is a benign process, as well as giving some return precautions. So what are the red flags? You should educate your families about what those red flags are, just to make sure that nothing was missed. So for kids that do have night complaints 4 or more times per week, it can be suggested to give naproxen at night before bedtime. That really can help sleep patterns, and it helps your sleep patterns too. So that's critical, or the parents' sleep patterns. So moving on to the second case. You have a 4-year-old Caucasian girl presenting to you with a limp. This has been a limp of an unclear duration. Seems like it's been going on for some time, but parents really have a difficult time determining when it started exactly. They think maybe she was wrestling with her brother and that it might have started after that. Very typical history. However, in the morning time, she walks like her grandmother, and that abnormal gait lasts for about an hour and subsequently improves with some activity. So by the time she's at school, she's actually doing quite well. She participates in all of her normal activities. That's impressive when you see some of these kids in clinic with their degree of arthritis. So there's no rash, no systemic features, weight loss, severe pain, or other joint involvement. So severe pain, this is really a mild to moderate pain complaint versus severe excruciating pain. So on physical exam, you see she's a cute little 4-year-old, and you can see that she has some marked swelling of that left knee. It's also held at a 30 degrees of flexion. This allows for the most amount of space within that joint capsule to accommodate for the joint, the fluid effusion. You might notice once you look a little bit closer that there's some muscle atrophy. So if you examine the child from the back, you can see that the calf development of that affected side is a lot less than the other side, as well as her quadricep muscles are atrophied as well compared to the contralateral side because of her inability to fully extend at regularly. So let's talk about what is arthritis exactly. What's the difference between arthritis and arthralgia? So again, arthralgia is just joint pain. Arthritis is when you're going to elicit a history of mild to moderate in severity. There's some morning stiffness. The length of the morning stiffness gives you an idea about how involved the arthritis is. If they're stiff for an hour versus 15 minutes, that maybe speaks to how involved the inflammation is of their joints. Gelling is also known as a movie theater sign. So some of us have this too when we're sitting for prolonged periods. You get up and your knee feels quite stiff. That's gelling. On exam, it's going to be the joint's going to be warm. You're going to notice some swelling, tenderness, pain on active or passive range of motion, and you're going to find a limitation of motion. So oligoarticular arthritis, so few joints. Differential, as far as autoimmune differential is concerned, is juvenile idiopathic arthritis. That's our most common diagnosis that we see in clinic. I'll be talking about more specifically oligoarticular JIA, which is further subdivided into persistent and extended subtypes. Persistent type is they continue to have 4 or less joints for the rest of the duration of their disease, compared to extended, where after 6 months they have more joints involved and they have a poorer prognosis. Also within the umbrella of juvenile idiopathic arthritis is psoriatic arthritis, as well as enthesitis-related arthritis. Enthesitis-related arthritis, an enthesis point is where the tendon or ligament inserts into the bone. These can be tender spots, and that would indicate that there is enthesitis. You can see this on ultrasound. You can see this on MRI as well. You just have to know where the typical enthesis points are in order to elicit that. And this is what we think ERA, or enthesitis-related arthritis, is the early spectrum of spondyloarthropathy, which is essentially arthritis of the central skeleton. An example of that is ankylosing spondylitis. We don't have very easy words in rheumatology, it looks like. So let's talk a moment, spend some time on oligo-JIA, since that's the most common diagnosis. And so by definition, it has to be 4 or less joints with arthritis. It predominantly affects the Caucasian population, even though all races are affected, least commonly in the African American population and Asian Americans. It's actually quite a common disease, and this is what we're trying to spend some time educating the community about, that there are some estimates as much as 1 in 1,000 children have a chronic arthritis. Some are self-limited, and some persist for some time. We get very excited about educating and getting these kids into our clinic because of the potential for limitation of growth if that joint inflammation is not controlled. The highest frequency of this oligo-JIA is young. This is 1 to 3 years of age. So being able to differentiate what is acute, subacute, fat, and a joint effusion can be terribly challenging at some points. But that's why it's important to compare contralateral sides. So you'll hear me say that a lot. Like all autoimmune diseases, females predominate as far as numbers or epidemiology is concerned. It affects mostly the large joints. It rarely begins in the hips. Oligo rarely begins in the hips. If you have a kid coming in with arthritis, older child, you're going to be thinking more of a spondyloarthropathy than you are of the oligo-JIA. Again, systemic manifestations are rare in oligo and may not appreciate a subtle difference between, I was just saying that kids are hypermobile. So you have a kid coming in, 3-year-old, who has a negative 10-degree elbow extension on the right side, and you're suspecting something on the left side, and you can only get to 0. Well, 0 is considered normal, but if you don't pay attention to that contralateral side, you might miss the arthritis. Complications of JIA. Uveitis, which I'll spend a little time talking about. Leg length discrepancy. So let me pose a question here. So if you have a kid coming in, let's say about 4 years old, who has arthritis of the right knee, you're quite confident. Is that right leg going to be longer or shorter? And you can answer that to yourself and quietly. The next thing is joint deformities. Joint deformities with long-standing uncontrolled inflammation. You can have deformities of the joint, which is potentially terribly devastating for the kids and for the families. So let's talk about the pathophysiology of chronic arthritis. So rheumatoid arthritis and juvenile idiopathic arthritis is characterized by transendothelial influx of specific inflammatory cells. So we have activated CD4 positive T cells coming into the joint space, as well as monocytes. Normally, the synovial cell lining is 1 to 3 cell thick. With chronic continued inflammation, these CD4 positive T cells end up activating monocytes, macrophages, and you get some downstream increased pro-inflammatory cytokines such as tumor necrosis factor, IL-1, and IL-6. And I'm mentioning these now because when I talk about treatment, we have targeted therapy for these pro-inflammatory cytokines. Joint deformities are caused by differentiation into osteoclasts instead of osteoblasts, so you have destruction of cartilage as well as bone. So this is synovitis. You might hear us saying synovitis or pannus formation. Etiology and pathogenesis. There's multiple HLA loci associated. There's not one clear, except for the spondyloarthropathies where we have the class 1 HLA-B27 marker highly associated with ankylosing spondylitis. So it's varied. The level of risk for the oligo-GIA is only mildly increased, and that's opposed to maybe the HLA-B27 diseases. It's phenotypically diverse in presentation. And like in a lot of autoimmune diseases, we have individuals who are genetically predisposed, that's the first hit, develop a second hit. And that second hit oftentimes is infection in the pediatric population. But it can be trauma or stress as well. Which is the one lab test you would order in a child with a new diagnosis of oligo-GIA? Some of you who have spent some time with us already know the answer. It's not ESR, it's not CRP, as I've tried to illustrate that there are no real systemic signs of inflammation. It's really limited to the joint spaces in this oligo-GIA subtype. Anti-nuclear antibody, that's the test that you're going to make sure you order in order for us to risk stratify for the development of uveitis. If they have a positive ANA, young age of diagnosis, female, new diagnosis, oligo-GIA, they're at high risk for the development of uveitis. 85% of all oligo-GIA patients do have a positive ANA, which speaks to the humoral involvement of the pathophysiology. It's more commonly found in young females. Other autoantibodies should be present. So what are these other autoantibodies? Double-stranded DNA should be negative, and RNP, Smith, some of these other autoantibodies that you might be familiar with from lupus investigations, they really should be negative. And again, the acute phase reactant should be normal. So uveitis, one of the most potentially devastating complications of juvenile idiopathic arthritis. This is inflammation of the anterior uveal tract and adjacent ciliary body. So what you have here is up to a quarter of oligoarticular patients can develop uveitis. And again, I just spoke about those different risk factors. That's why it's important to obtain that ANA. It helps us figure out if they need to see the ophthalmologist every 3 months or every 6 months and so on. The important thing about uveitis is that it's asymptomatic. So we have a fairly aggressive screening protocol with our pediatric ophthalmologists so that we don't miss something. If we miss it and there are symptoms, that means that there are complications and essentially there potentially is permanent damage. As you see here, there's 15% of affected patients can have vision loss as a result of uveitis. So what happens here is you have chronic inflammation in the anterior chamber. You can have scar tissue fibrosis connecting the iris to the lens. I have a picture of that. It's called synechiae. You can develop glaucoma because these inflammatory cells do not allow for appropriate drainage of the aqueous humor. You can have cataracts from the inflammatory cells causing opacity of the lens. This is posterior synechiae. And this is something that you can see on physical exam, but if you see this kid coming in and they have this is late. They've had long-standing uveitis. There is such an entity as idiopathic uveitis, so not all uveitis is associated with autoimmune disease. There's also infectious causes of uveitis, but in the context of autoimmune disease, this is long-standing, uncontrolled inflammation. So our adult rheumatology colleagues are jealous of us because oligo-GIA patients, there is such a thing as sustained remission in this particular subtype as compared to rheumatoid arthritis patients where there's really no true sustained remission. And that's a big goal and target, but we're not there yet as far as the current medications that we have. So many resolve within a year. 75% will experience sustained remission. And really, it's within that first 5 years that we're monitoring quite closely for recurrences. Poor risk factors for poor prognosis can include ankle and wrist involvement, as well as those inflammatory markers. Remember, I said those should be normal. So what are the infectious causes of an oligoarthritis? Now we're moving away from the JIA autoimmune causes. If you see a kid coming in with arthritis and they have profound elevation in their acute phase reactants and there's an acute onset of pain, you're going to be thinking more of the infectious etiologies. Of course, septic arthritis is a critical one for you to think about because of the potential for joint damage. It's an orthopedic emergency. Osteomyelitis, and I always include Lyme disease, but here in Los Angeles, you'll always have families requesting Lyme titers, but really think about the risk factors. If there are no risk factors, there's no need to be looking for Lyme disease. If you have a child presenting with relatively new onset of symptoms and you feel confident that it's relatively new, yet they have destructive arthritis, think about tuberculosis, and again, you're going to be asking for risk factors. Hem-onc differential diagnosis for oligoarthritis. Joint pain in a 2 to 4 year old girl plus severe pain, plus periarticular pain. There are systemic features there. There's non-articular bone pain. That's not JIA. Neuroblastoma, you might have some Mets to the bones, sickle cell, hemophilia with the hemarthrosis. So this is a girl that was initially diagnosed with JIA, but if you see here on the plain film, there are subphyseal lines or leukemic lines. She eventually had a bone marrow and she was diagnosed with ALL. This is unusual, but something to remember. Other differentials for oligoarthritis are reactive arthritis, so post-GI-GU infection, obviously trauma, osteonecrosis. Now moving on to polyarticular arthritis. What are the autoimmune causes of polyarticular arthritis? Polyarticular juvenile idiopathic arthritis, and that's defined by 5 or more joints. I'll get to that in a little bit. Connective tissue diseases such as lupus or mixed connective tissue disease can present with arthritis in the beginning without necessarily all of the classic or diagnostic autoantibody features or other systemic features, so something to think about. Let's spend a moment on polyarticular JIA. So there's 2 peaks. First peak is between the ages of 2 and 5 years. It's an indolent course, like you heard me say for the oligo, JIA. It's symmetric. Uveitis can occur, and they're rarely rheumatoid factor positive. That's that RF. So this group probably is quite similar to the oligo JIA as compared to this second peak here. So there's definitely some different genetics playing a role here in this early versus late. This is a relatively rapid onset. These kids look more like the adult rheumatoid arthritis. Polyarticular, symmetric, rapid onset, every joint involved. I want to highlight that cervical spine as well as TMJ joint, TMJ can be involved as well. So important to assess that, in particular cervical spine if they're an active athletic kid. Rheumatoid factor positive, really more like the adult group. They have a poor prognosis and only about a 5%, only 5% of those RF positive patients end up in sustained remission, maybe even less. So the labs here are a little bit different. You're going to see some signs of systemic inflammation here. Anemia of chronic disease, you might have some hypergam. ANA positive is more common in the younger group, but you can have ANA positive here. And the rheumatoid factor. So if you have a little kid coming in, really less than 7 is not helpful. If we're doing clinical trials, oftentimes we'll check for all these autoantibodies, but generally not helpful diagnostically in a younger child. Complications, as I had mentioned, flexion contractures, bony erosions, joint destruction, TMJ involvement can be debilitating. And I had asked you the question about which leg was longer, affected leg. So initially, the affected leg is longer because as you remember from that synovitis panistis illustration, there's hyperemia to that growth plate. Hyperemia The growth plate says, oh, great, more food, let me keep on growing. But at a certain point, there's premature closing of that growth plate. So the leg is eventually shorter, initially longer, eventually shorter, if uncontrolled. So you can have micrognathia as a result of chronic inflammation. And what's the course, as I had alluded to before, RF positive, worse course, poorer prognosis for sustained remission. Some other immunologic causes of polyarticular arthritis, I'm moving away from the JIA. Reactive arthritis, serum sickness, so you're going to get a good history of drug exposures, viral infections. Immunodeficiencies, you're going to get spinopulmonary history, see if there are multiple infections with regards to that. CRMO, really not as much the joints, but it can be confusing as far as their presentation is concerned. And other differential, this is rare, but it's interesting. Progressive pseudorheumatoid arthropathy of the childhood. This is a type of epiphyseal dysplasia, and there is a genetic association with this. But symptoms begin around the age of 3, similar to oligo, or the younger age poly. And they can have joint pain and deformity, but without the typical inflammatory markers. So let's move on to arthritis with systemic features. I've been talking about arthritis without, for the most part, systemic features. What are the autoimmune disease causes? So the big one is systemic JIA, again, one of the subtypes within that JIA umbrella classification. Connective tissue disease. So it's important to remember, and I'm going to reiterate this again, that oftentimes connective tissue disease, depending on the type of patient that's walking in, you have to know a little bit about the epidemiology of some of these connective tissue diseases. So lupus, MCTD, more common around pubertal period, more common in, let's say, Latino, African American, Asian American population. If they're coming in with a polyarthritis, I want you to think about maybe this is something a little bit more involved than just in the joints. And then, of course, inflammatory bowel disease can present. So let's talk about systemic JIA. So arthritis can be oligo or poly. It's really characterized by fevers of at least 2 weeks duration. So these are the FUOs that you see in inpatient. And it's quotidian or a pattern predictable for at least 3 days. It's also accompanied by one of these other symptoms, including a rash. On board, salmon-colored rash, migratory. Really key is migratory. If you have a rash that is not migratory, that is not consistent with a systemic JIA rash. Generalized lymphadenopathy, hepatosplenomegaly, and you can have some serositis with this as well, again, systemic. This is a picture of a classic salmon-colored rash. And whenever I talk about systemic JIA, you're also going to hear me at least have one slide on macrophage activation syndrome. Systemic JIA affects, it's really only encompasses about 10 to 15% of all the diagnoses of JIA. However, it contributes the majority of morbidity and mortality to all of those groups. And why? They're sicker, it's systemic, but then this macrophage activation syndrome process, which is also known as secondary HLH, and that's when you have an acute onset. And sometimes these kids with systemic JIA present with MAS. So it can be very confusing. It's hard to really say for certain at that time, at that initial hospitalization, that this is systemic JIA with a secondary MAS. It can be hard to say. But they look like they're in DIC. If you see a fall, so relative drop in the WBCs, platelets, ESR, that actually is not reason to celebrate. That might be because they're really evolving into this MAS picture and needs help quite quickly. And help is IV steroids, and if that doesn't work, so pulse steroids, if that doesn't work, cyclosporin. It's defined by, you don't necessarily have to have the phagocytosis seen on bone marrow biopsy. There are some other criteria as well, but it's very helpful if we do have that on bone marrow biopsy. Infectious causes of arthritis plus systemic features are long, but just in brief, bacterial infections as listed and a whole host of viral infection. I'd say the more common would be the parvo, EBV, CMV, and hepatitis B, but all the hepatitis can cause it as well. We don't see so much malaria here. oncology malignancy, and then immunologic, molecular mimicry causing signs of acute rheumatic fever. So our case presentation. So she was diagnosed with oligoarticular JIA with a complication of a leg length discrepancy, as well as a flexion contracture. She was found to be ANA positive, and so she was at high risk for the development of uveitis because of her age, her gender, ANA, and new diagnosis, recent diagnosis. So what do we do? This is potentially, depending on the involvement, but this is potentially a devastating disease for really families. A lot of times these kids are really young. They don't understand completely the ramifications of this diagnosis. But this is a chronic disease diagnosis. And so we give them a lot of education. These kids do terribly well. They do very well, especially if they're able to take their medications regularly, as well as comply with some of the physical therapy, home exercise programs. That's really a critical part of rehabbing arthritis. So she earned a screening by a pediatric ophthalmologist for every 3 months for 4 years, then every 6 months for 3 years, and then yearly thereafter. That's a pretty intense screening protocol. But I hope you understand from the previous slides that preventing uveitis, again, because it's asymptomatic, is quite critical. So just to review some key points to history, you're going to ask about duration. The severity will help you distinguish between inflammatory and non-inflammatory causes of joint pain. How many joints? The more joints, typically, the less likely they will have a sustained remission. And again, sustained remission means they're probably going to have some arthritis into adulthood. And that's difficult telling parents that when I'm saying that they have a polyarticular kid who's 2, and I'm talking about adulthood. Does the pain wake the child up at night? Any precipitating events? We always ask, was there an infection a few weeks or a month before the onset of these symptoms? Are there systemic features, other medical problems? Of course, with psoriasis, on physical exam, you're going to be looking for nail pits. You're obviously going to be looking for psoriasis, as well as a family history. Family history of psoriasis, first degree, that's a high risk for development if you're suspecting arthritis. And IBD, inflammatory bowel disease. So key points to physical exam: spine flexibility, which is important, especially in those spondyloarthropathies, again, those that affect the central skeleton. Leg length discrepancy. Brachydactyly, so as I was describing, initially that leg is longer and then it becomes shorter. Well, same thing with the toes or fingers as well. Not as much because obviously the legs have the largest potential for longitudinal growth, but you can see some brachydactyly with chronic uncontrolled polyarthritis. And skin, as we discussed. The heliotropic rash and Gauthron's papules, that might ring a bell for juvenile dermatomyositis. JDM can have arthritis as part of their picture, so something to think about as well. But they're going to be weak by definition. Some of the basic labs. Again, rheumatoid factor, if they're young, not helpful unless they're in a trial. And then the anti-CCP antibody is more specific for chronic arthritis than the rheumatoid factor is. And that's been commonly used in adults. We're using it in pediatrics too. So imaging. If you're concerned about a kid, first thing you're gonna do is you get a plain film. That can help you quite a bit. It generally tells you about damage or inflammation that's been occurring for some time. There's nothing new. It's not gonna show you a lot of activity unless there is a huge effusion. But as you can see here, there's quite a bit of asymmetry between these two wrists. So on the left, these carpal bones are osteopenic. There's narrowing of the joint space as compared to the right side. You can see some bony erosions here and irregularities. So this is long-standing uncontrolled inflammation of the joints. So what does this wrist look like? Well, she can't, probably her extension is limited to about, it should be about 80, it's probably limited to about 30. When you're talking with kids about how they're able to keep up with their friends, they can't do push-ups if they're an older kid. They really are limited and feel different from their peers. So now moving on to ultrasound. I'll let you read that. I thought that was kind of funny. This is what most people think about with ultrasound. You know, it's like a war shock. What do you see unless you're trained? But actually, imaging quality has improved quite a bit, even in the last 5 to 10 years, quite a bit. So as an example, here as a gross anatomy of the suprapatellar recess, so right above your patella. This is the patella here, the femur, prefemoral fat pad, and here's the tendon, rectus femoris. This is the skin up here. And right in here is the suprapatellar recess, and the analogous ultrasound image is here, suprapatellar recess. Femur, prefemoral fat pad, patella. You can see this is very dark here because ultrasound waves do not penetrate bone. Tendon. It's pretty good, isn't it? I think it's pretty good. I think again, the image quality has improved quite a bit. So how are we using this? Well, ultrasound can help detect joint effusion, synovial hyperplasia, and abnormal power Doppler signal. Those are all evidence of chronic inflammation within the joint space. I'll talk about power Doppler a little bit more on the next slide. We can look at joints, bursas, tendon sheaths, and it's more sensitive than Xray in detecting cortical erosions. We can also use ultrasound to essentially help us determine if kids we can start withdrawing medications on children, so we can use serial ultrasounds. The key point, the reason why ultrasound is so critical, and I'm surprised it hasn't started a lot sooner, is because with pediatrics, MRI is the gold standard for evaluating for chronic arthritis. But as you know, MRI for a 2 or 3-year-old also requires sedation and its own risks related to sedation. So ultrasound, you can do multiple joints at the same time, and you can interpret it right then when you're doing it. So with pediatrics, again, sedation risk, but also when we have kids coming in particular the ones that require biologic therapy, which I'll discuss in just a moment, we are asking them to weigh the risks versus the benefits of the medication, but the risks can sound quite scary, including really serious infections. And so if we can get these kids off of medications in a safe and effective way by examining them, seeing that they do not have evidence of clinical arthritis, and then putting the ultrasound probe on their knee, wrist, whatever, and ensure that there's nothing there, we can feel more confident that if we withdraw the medication at that time, that they're not going to have a relapse quite soon. At this point, ultrasound use in pediatric rheumatology is in its nascency, so we don't have a lot of normative data. That's what we're collecting at this point. But it'll get there at some point in time. And again, the differences between the pediatric joint with the adult joint is what we already talked about. Kids have open physes. Adults don't. Cartilage in ultrasound looks black because it's mostly made of water. Well, so does a joint effusion. So it can get a little complicated when you're trying to really use ultrasound in peds specifically. And importantly, it'll help us guide joint injections so we can make sure that we're putting the steroid into the correct location. There's been some interesting studies looking at mostly adult rheumatologists that have been practicing for years and years, decades. And they feel quite confident of the accuracy of their steroid injections. And so they did a study looking at the accuracy blind compared to ultrasound guided. And ultrasound guided was superior to the blind, even though very experienced rheumatologists. So what's power Doppler? So power Doppler is able to measure low velocity flow signals. As we talked about before, there are normal nutritional vessels going into the physes. So being familiar with what is a nutritional physiologic vessel versus a pathophysiologic vessel is important in the differentiation. With persistent inflammation, you're going to have abnormal power Doppler signals as opposed to what would be expected as far as the appearance of a nutritional vessel. Important to differentiate between the two. So what are the implications? I touched upon this recently, but in the kids with active disease, if I have someone coming in that I'm confident has 2 joints with active arthritis, as you now are familiar with, I'm going to diagnose them with an oligoarticular JAA if they fit the other parts of that diagnosis. And let's say I do a 27 point joint count and ultrasound evaluation, and I find 8 joints with arthritis. Ultrasound will be changing the way that we classify our kids. So what does it mean to have ultrasound-defined subclinical inflammation compared to clinical inflammation? So everything will be changing soon. In addition to all the genetics that we're learning about as far as etiology of these diseases as well. So for those kids that have inactive disease or are thought to be in remission, so the ones that we're talking about dropping medication, again, what we found is that we underestimate the amount of synovitis on exam. And then at our work here, we found about 30% of patients who we thought were in clinical remission indeed had some evidence of subclinical inflammation on ultrasound. So again, eventually, once we get some normative data, we need a lot of data collection before we can really incorporate this into remission criteria. This is where we are now. And at this point, it's terribly helpful in the clinical setting. So just a moment on treatment. So we want our kids to grow. How do we have them grow? Well, we'll start with Arthralgias. And again, that's a non-inflammatory cause of pain. It depends what the etiology is. So if you have a kid coming in with patellofemoral syndrome, I already had discussed what the treatment is. It's really a lot of physical therapy, as well as some NSAIDs, plus or minus. If you have a kid coming in with hypermobility and they have profound pes planus, hindfoot valgus, you're going to be focusing on orthotics, as well as joint protection of their fingers. So a lot of kids will have, who are hypermobile of the hands and don't necessarily meet criteria, are hypermobile of the hands, have a lot of pain after a day of writing. So then we send them to occupational therapy, and they are taught ways to hold the pen, things not to do, in addition to things to do as far as muscle strengthening. It's really about strengthening the muscles around those hypermobile joints. So arthritis. These are the key parts these are key options for us when we're deciding what's the best approach for treatment of arthritis. Non-steroidal anti-inflammatory drugs are first line, depending on the type of arthritis. And the type, as far as pediatric specific, ones that are in a liquid formulation are ibuprofen, as you know, naproxen, which we probably use most commonly, even though there's been some shortage of that by the manufacturer. Meloxicam is another one, that's a once a day, as well as indomethacins. Those are liquid forms of NSAIDs. Typically given 7.5 to 10 milligrams per kilogram per dose for the naproxen as being the most commonly prescribed. Methotrexate, for those residents and interns who maybe are on HEMONC, you'll hear about methotrexate as far as being a standard treatment for leukemia. The first thing that I tell parents when they walk in the door and I'm going to be discussing methotrexate is do not look this up on the internet. Because all that's described on the internet are high dose cancer, chemotherapeutic doses and its side effects. So we have our handouts. We reiterate, do not look this up. Please do not look this up. And say that essentially this essentially has a different mechanism of action at this dose. We use 0.5 milligrams per kilogram or 10 to 15 milligrams per meter squared. It's given once a week, oral or subcutaneous. And it's very well tolerated. It's been used for over 30 years in arthritis, adults and pediatrics. So we feel quite safe about this medication. Side effects can be usually involve transaminitis, which if you adjust the dose, hold the dose, will resolve. Unlike maybe in some of the adult population, there's reports of, there is associations with hepatic fibrosis. And then moving on to biologics. Really, biologics are what has changed rheumatology and has affected the way kids are able to function. And I don't think that's an overstatement. It really has changed rheumatology. And then, of course, intra-articular steroid injections, which we use with significant frequency because this has a great effect. One obvious problem is a young child who is not going to stay still for you, especially if it's two joints. So then we talk about sedation. We do it upstairs in the outpatient surgery center. So this can prevent leg discrepancy. If you have a knee arthritis, you give the injection, this can really help. Again, local therapy, a lot better than something systemic if there's only one or two joints involved. So in 2011, the American College of Rheumatology decided to put out treatment recommendations for JIA. And it started with, one of the algorithms was for arthritis involving 4 or fewer joints. So to remind you, that's the oligo, that's the psoriatic arthritis, potentially enthesitis-related arthritis. And you'll see NSAIDs, steroid injections, and then methotrexate a little bit further down when you're talking about escalation of therapy. And on the bottom here, you'll see TNF inhibition. This is unusual for an oligo to go all the way to biologics, but it can happen. And it's based off of disease activity as well as poor prognostic features, which I won't get into the details, but it can involve those elevated persistent inflammatory markers, as well as ankle and wrist. There's some observational data on ankle and wrist involvement being a poor prognostic factor. Bony erosions, of course, too. Algorithms for 5 or more joints. So methotrexate, we're going to be starting a lot quicker. Biologics, we're going to be starting a lot quicker because we know the prognosis is worse and the potential for joint damage is worse. So a moment about biologics. There are several mechanisms of action of the different biologics. First, targets these pro-inflammatory cytokines. As I had mentioned, the TNF, IL-1, IL-6. There are many different ways that that's done with the various medications that are available via monoclonal antibody or a soluble receptor protein. And then secondly is inhibiting second signal for T-cell activation. So we have a medication, abatacept, which provides a CTLA-4 signal, which is inhibitory in nature, compared to the CD28 signal, which is activating, which would subsequently give that second signal to the T-cell and activate those T-cells, which thereby has the downstream effects producing these pro-inflammatory cytokines. And then the B-cell depletion, CD20, rituximab. Not everything that we use is FDA approved. Almost everything, infliximab is something that we still use for JIA, but we're now with the increased randomized clinical trials, we're able to get FDA approval for a lot more medications. Unfortunately, there's still a lot that we're not able to use because of the performance of the RCTs only in adults. So because of the development of these new biologics and new data coming out, in 2013 they produced an update for the 2011. And it really was based off of these 2 studies regarding canakinumab, which is an IL-1 inhibitor, monoclonal antibody, as well as tocilizumab, which is an IL-6 monoclonal antibody. And both these studies were in systemic JIA patients. The results were profound. At 3 months, there was a significant improvement, and it was sustained improvement at even 1 year, where 80% of patients had a 70% response. So based on this data, this is what was from the 2011 initial guidelines. So they decided to make things a little bit simpler. I'm joking, this is not simple. When we first took a look at this, we were saying, wow. But it's important that we have to incorporate all these new biologics. And again, if you look back here, anakinra does not have an FDA approval for systemic JIA, but that's the medication that we had the most data on. So then we move here, and then you see canakinumab, tocilizumab, all these newer medications. So I'm not going to quiz you on this, but there are guidelines, and it has to change based on the rapidity of the development of these medications. So just to review the medications, IL-1 and IL-6 specific to systemic JIA. And to conclude, a detailed history and physical exam really can distinguish between these inflammatory and non-inflammatory causes of joint pain. Labs help to complement your good physical and history, and incorporating imaging is a critical component as much as labs and physical and history. And an appropriate, timely diagnosis with these kids with arthritis will allow for appropriate management and minimizing the potential for joint destruction and appropriate growth. Thank you.